Hello, welcome to the Mayo Clinic. My name is Julie Cunningham. I'm the Director of Clinical Practice in the Pharmacy Department at Mayo Clinic, Rochester, Minnesota. My clinical practice is in the Mayo Clinic pain rehabilitation with chronic pain patients. Topic today is chronic opioid tapering, pearls for the primary care provider. Our learning objectives today, I'm going to provide you with an overview of the literature on opioid tapering, as well as talk through some of the tips and tricks related to this process, and then finally have some case examples to share with you. Opioid discontinuation. So it's really an art and not a science. And the literature that we'll talk through very much demonstrates that. For talking with your patients, opioid tapering may be a scary word, and using words like opioid discontinuation, opioid exit plan, or even de-escalation of opioids, which is a term that maybe we use more with polypharmacy, could be something that's more comfortable for them. The literature that we'll talk through really tells us that it is not a science, it's an art, and that we have to really individualize this for the patients. So the first article I want to reference for you today is one written in 2015, just 5 years ago, and this was published in the Mayo Clinic Proceedings. And the goal for this information was to summarize the literature related to tapering chronic opioid patients who are on opioids really for non-cancer related pain. 5 years ago, the information that we had and how we tapered is really different than how things have changed over the last several years. Part of the information from this study talked about when you might rapidly taper somebody, and the guidelines given were even 25% reductions daily. Now this is likely more for your patient who's an inpatient setting versus an outpatient setting, and the goal is to reduce acute withdrawal. When we're tapering in the primary care setting, our goal is not for the patient really to have any withdrawal symptoms. We want it to be a comfortable process, really minimize that distress for the patients. So kind of bottom line for this particular study, the authors talked about their best practice recommendations from their experience. And again, 5 years ago, that was about a 10% reduction of the opioid dose each week until they reached that point of about 30% of the original dose, and then slow down the speed of the taper and then reduce by 10% weekly at that point. So the US VA also has guidelines that they have published. And recently they updated those guidelines in 2017. And it's very interesting that this recommendation from the VA is about a 180-degree change from what they had published previously, which talked about weekly tapering. And the guidelines published in 2017 had the goal for more careful and cautious tapering. And the recommendations here were in the lines of 5 to 20% reductions every 4 weeks, or monthly tapering. They also gave us some guidelines for patients who might be at higher risk, those that are non-adherents to their treatment plan, as well as those with high-risk medication behaviors. And in those cases, weekly reductions are probably appropriate. Now, in 2019, the Department of Health and Human Services put out a guideline for clinicians that really are meant to help us understand that we need to be more gradual and cautious with our tapering approach. And within these guidelines, they talk about what risks the patients have. So chronic opioid patients generally think about tapering opioids as not a life-threatening type of situation, but tapering opioids actually can increase that risk for depression, anxiety, and can lead to suicide, or for patients to even seek illicit type of products to substitute for their opioids. So it's important to understand the risks, to identify our candidates who we would be tapering those medications are, and to have a shared decision-making process with that patient. So really collaborate with our patients and do this in a way that is going to provide the most safety to the patient. Along with those guidelines, subsequent to that, in the Mayo Clinic proceedings, there was a consensus guideline that was put out from many providers across the United States that practice in chronic care pain practices. And they provide more detail to the HHS guidelines and help us to understand, again, we need to identify those risk factors for patients. And for those patients who maybe need referrals, such as psychology, psychiatry, addiction, behavioral type of treatment, as well as patients who maybe just need to be more stabilized before suggesting tapers. So along with tapering plans, we need to look at what other medications might be supportive in that process, whether it's non-opioid pain-related medications or adjuvant medications to help reduce withdrawal symptoms. They also spend a bit of time talking about the option for buprenorphine for patients who really are on high doses of opioids and have not tolerated reductions in the past. They recommend closely monitoring patients. And then another point that they emphasize is not to abandon patients. There's been a lot of information recently on social media from the chronic pain populations that are critical of healthcare providers because they are forcing tapers and abandoning patients through this process. So again, very important to have a collaborative conversation with patients as we start through the process of tapering. From my experience in the Mayo Clinic Pain Rehabilitation Program, we taper patients off of their opioids. It's one of our core pillars in our program. And our program is one with an emphasis on behavioral rehabilitation. But patients who come to us on opioid medications, part of their treatment plan is to taper off their opioids during that time. Our program is a 3-week program, so this would really be considered by most to be a very rapid taper to discontinue the opioids in a 3-week period of time. However, we've been able to be successful with this approach because of the daily touch points with patients and the behavioral approach. As we're reducing that opioid medication, we're really substituting it with other skills that the patient is learning and incorporating into their daily routine. It's important that you continue the patient's medication that they're on. We aren't substituting one opioid for another and tapering down from there, but we really taper them off of what they're on, reduce the dose of the medication, and then finally reducing that interval. We've also learned that there's some patient factors that we should pay attention to. Those are the patients that have been on opioids longer, they may struggle more with this process, and so it needs to be more gradual. We need to consider perhaps some of those more adjuvant medications supporting them in that process. Although adjuvant medications aren't something that we automatically add for tapering, it's really individualized and based on the patient. Also, those that have increased psychiatric comorbidities, we want to make sure that these are managed well. Other medical comorbidities, such as high blood pressure, increased heart rate, as we're tapering the opioid medications, that may actually increase and worsen. So from a starting point at baseline, we want to make sure that's really well managed. And then finally, those patients who have increased potential for distress with the taper, those that maybe have poor response to stress, such as adrenal insufficiency that's secondary to opioid use, or those patients who are on steroids, they may be more susceptible to the distress of tapering. And so again, we want to provide them with more support and perhaps have a slower gradual taper. We do monitor those withdrawal symptoms. So on the screen, you can see the Clinical Opioid Withdrawal Scale, or COWS, and this is something that can be administered by clinicians. There's also another scale that's a SAO scale that is a self-administered scale for patients. So it's a way to kind of keep track of how well the patient is doing, what their withdrawal symptoms are. Our goal, again, though, is to really minimize withdrawal symptoms, and as we see this climb, we realize adjustments might need to be made. So for a typical patient in the outpatient setting who's having weekly, monthly opioid dose reductions, this may not be necessary, but it's important for the clinician as well as the patient to be aware of what withdrawal symptoms exist, and again, to help support the patient's distress related to this. Let's talk about some of the barriers that you might anticipate with discussing tapering with your patients. So many times we don't even want to start the conversation because we worry that our patient is going to be upset with us, that they're going to be angry. And there is some truth to that not all patients are going to be excited about tapering their opioids. But we do know that those patients that are more in agreement, that collaborate with their providers, are going to be more successful. But also, not all patients are going to be upset and angry. So a recent study in pain in 2019 actually looked at this question. They had patients that were referred to a pain clinic go through a voluntary study, and the study was a simulation study. The patients were all chronic pain patients who were on opioids, and then they were asked to view a scenario of another chronic pain patient. They heard that patient's story and heard details of their experience. And then they were randomized to 3 different simulation scenarios where the provider either recommended continuing the opioid medication, recommended changing the medication, or they recommended tapering the medication. And then the patients in this study were asked to record their response to viewing that simulation. And interesting, what they found is that they saw higher positive and enthusiastic responses to the simulations that involved change to therapy or tapering of their opioid medication. They also found that the patients that recognized that they felt anxious by viewing that anxiety didn't necessarily correspond to a positive response. They did, however, find that a connection with patients who were on opioids longer were less likely to have a positive response. Another concern you as a provider may have is that as you taper their medication, their pain is going to become more prevalent, and that you might have to start a different medication. You might have to increase their opioids. And there is conflicting information, of course, in the literature that looks at this, but a large systematic review that was recently completed looked at 20 different studies. Now, these studies were not randomized controlled studies, but they were studies that looked at that tapering process and recorded patients' level of pain at baseline and then at completion of the opioid taper. And over 80% of the studies actually showed a significant correlation with improved pain or no change in their pain score. There's also a VA study that was recently published with over 500 patients, and tapering opioids over a 12-month period of time, they also found that the pain was not worse in those patients, and in fact, they found some slight improvement in pain for those patients. And then finally, there's the concern that patients may actually terminate their care with their provider if they are in that process of tapering. And a study recently did find that this is true. It was a large study of over 1,600 patients on chronic opioids, and they looked at that subset of patients that were required to taper their opioids. And they found a odds ratio correlation of 4.3 that showed indeed that termination was found to be more likely with those patients. However, some limitations of this study was, again, it was retrospective. We really don't know why the patients were tapering in these different situations. And the tapering definition that they used was a 30% reduction in the past 6 months. So likely a number that may correlate with some increased difficulties with tapering. So now let's talk about some expectations that's important to set before starting a taper. It's important to have a shared decision-making model with your patient. Really clearly define what the management plan will be. Talk about what's negotiable with the patient and what's not negotiable. So some examples might be that you can negotiate which medication you would taper first, or even negotiate the strength of the tablet size that the patient is going to be prescribed. But maybe a non-negotiable would be that you would be their only prescriber. So you would be monitoring the prescription monitoring plan within your state and watching to make sure the patients aren't getting opioid medications or even other controlled substance medications from other providers. It's important to have an opioid agreement plan signed with the patient. Again, these plans are really not meant to be punitive, but it's agreement between what's expected of you as the provider and for the patient. So it's an agreement between the two of you. Before tapering, talk about what referrals you think would be important for the patient to have. Would a pain rehabilitation program be very helpful for them in the process, not only of tapering their opioid, but also just better managing their pain? Cognitive behavioral therapy, addiction services, and then talk about what anticipated obstacles may be something that this individual patient may experience, and asking the patient what they would anticipate as being an obstacle. Some of that shared decision-making, communication. So communication is really key. We need to explain the reasons why we think tapering is important. Talk to the patient about their progress with their pain management on their opioid, or most likely lack thereof of progress. Talk to them about how being on an opioid in some cases actually can increase pain, and this is referred to as opioid-induced hyperalgesia. You can negotiate with the patient to some extent. It's important for the patients to feel, again, that they're a partner and that they have a say in how this is going to be done. And so that might be the rate of the taper, or again, just some of the details of how the taper is going to be managed. You also might expect you could have some difficult, crucial conversations with the patient. So it's good to think about these in advance of talking to the patient, maybe practice the scenario, reach out to colleagues and get their support in running these conversations by them for some tips and tricks on how you can really do this best. And then finally, really important, make sure the patient knows that your goal is not to abandon them or to dismiss them from your practice. Your goal is to work with them for a better ultimate care by reducing these opioid medications. It's important to consider non-opioid therapies. Now, it's really out of scope for our conversation today to go through what these non-opioid therapies are. But one point that I want to leave with you is consider things maybe that the patient has tried in the past. Often chronic pain patients really have been on multiple different agents and they have failed them or perceived that they failed them. But maybe why they failed relates to what other medications they were on at the time, other environmental or psychosocial type of situations at the time. So don't rule out things that they have tried before, and maybe talk through those options with the patient initially. You may not start those medications with the taper, but things to kind of keep in your back pocket as an option as you go through that process of tapering. And when you hit some of those points that might be difficult for the patients, talk about maybe it's time to start this other particular medication to help support the process. And then finally, think about prescribing naloxone for your patients who are tapering. If they have not already been prescribed naloxone and have naloxone at home as a rescue medication for opioid overdose, now is the time. Now, as a patient and maybe even as a provider, it may seem non-intuitive to start naloxone prescribing when a patient is tapering. But tapering opioids can actually put the patient at risk for overdose. As the patient reduces their dose, their tolerance to opioid reduces, and they are at increased risk for overdose if they resume taking some of the medication doses that they took in the past. They may feel that they tolerated it in the past, they did well, and so they themselves may not anticipate the risk of increasing the dose for short periods of time if they're struggling. Or they might add in other medications such as benzodiazepines, muscle relaxants, and these additive effects can also increase their risk for overdose. So talk to them about naloxone, encourage them to get that prescription filled. Most insurances really cover naloxone these days, and it's a very minimal cost to the patient. So finally, we're going to go through some different case examples. We have 3 different cases to talk about today. And the first case is a patient who is what we consider to be on a lower dose of morphine equivalents. So our case example, LB, she's a 46-year-old female, and she has fibromyalgia. She's been on hydrocodone acetaminophen, 10/325 milligram tablets, 1 tablet 4 times a day for the last 2 years. So she's been on this for a couple years. She's on it for fibromyalgia, which is an indication where opioids are not considered to be appropriate. And because fibromyalgia causes sensitization, adding in opioids can actually increase that risk for some of that pain the patient experiences. So you and the patient have kind of gone through all the process of talking through the expectations, so it's time to talk about details of how you would taper this medication. So her overall morphine milligram equivalence on that dose is 40 milligrams per day. As we think about a taper, because she's been on it for 2 years, we want to do this in a gradual way. So monthly reductions would be appropriate. Because the dose is on the lower side, you really can reduce that dose by the same increments each month without trying to stop at some point and reduce that amount. So as you can see on the screen, here's an example of what her taper may actually look like. Now, at that halfway point, you're using half tablets of the current strength she's on, the 10/325s. So once she gets to a half tablet 4 times a day, you can switch to that lower strength. Very important to talk to patients when you're making those strength changes so that they don't misinterpret. Many times when people are used to taking a prescription, they don't read the bottle closely. So closely communicate when you do adjust strengths for patients. But at that point where she's on a total of 20 milligrams of the hydrocodone, you can switch to the 5/325 tablets. So instead of taking a half of the 10s, she's going to take 1 tablet 4 times a day. Psychologically, to the patient, it almost feels like she's taking a little bit more too. So she's taking a whole tablet instead of a half a tablet. And then from there, again, you're reducing by that half a tablet until she's completed the taper. So some things to think about as you're going through the taper process. So why might you need to slow that taper down? So the patient may not be experiencing withdrawal symptoms, but she may have a lot of distress. She may feel that she's not able to manage her pain, even though, again, withdrawal-wise, she's doing well, and functioning-wise, she seems to be doing well at that point. So what you might do at that point is to consider talking to her about an evaluation with psychology, psychiatry, perhaps cognitive behavioral therapy to really help support her. Or maybe some adjustments to other medications, again, to kind of help manage some of those symptoms she experiences. So you might want to slow her taper down as you're trying to add in these different skills for her to support. So maybe you slow that taper down to every 2 months. As previously discussed, you might see some red flags in this patient. She may be running out early. She may be more angry and upset about the process. And so maybe an addictions referral is appropriate, and maybe you continue the pace or maybe even speed it up a little bit depending on some of the circumstances. Our next example is an older patient. So many times we do see elderly patients who are on opioid medications. And this next case is AC, and she is a 78-year-old female, and she also has fibromyalgia, but she's on oxycodone extended release, 40 milligrams twice a day, as well as a oxycodone immediate release, 5 milligrams 4 times a day. And she's been on this for the past 5 years. Certainly, she's an older patient. We have a lot of concerns with this high dose of opioids. It may increase some of her risks for things like falls and cognitive decline. Now, where we have the negotiation point we can bring in here, it's not really important if you taper the long-acting first or the short-acting first. In fact, you might want to taper the long-acting down to a lower dose and then hold that dose, and at that point taper off the short-acting medication. So you can talk to the patient about what they think would work best. And often when you're talking to those patients about that, you might even find, actually, I don't even take the short-acting medication 4 times a day. I only take it 3 times a day. So then that might be the first step, is to really reduce that medication. We have an example on the screen of how this taper may look as well. And in this case, we're reducing that long-acting medication. first, and we're completely eliminating it. But while we're doing that, we're holding the short-acting stable. And then at the point of where we've discontinued the long-acting medication, then we begin reducing that short-acting medication. Again, this is just an example. It could be done differently, and using that patient's preference sometimes helps get their buy-in to that process as well. Also within that tapering example, it demonstrates where we're tapering by a higher percent initially, but then as we're going through the tapering process, you can see on the right-hand side that the overall reduction from their baseline dose is getting smaller as we get closer to the end of the taper. And our final case example, this is a male, NJ. He's a 37-year-old male with chronic back pain. And he's been on a fentanyl patch, 50 micrograms per hour, which he changes every 3 days, along with oxycodone immediate release, 5 milligram tablets, and he takes those 3 times a day as needed for the past year. So only a year duration for this one, so a little bit shorter than our last 2 examples. Some things to kind of keep in mind here. His immediate release oxycodone is as needed. Understand how the patient is really taking this. Does he take it on a daily basis? Or does most days he really doesn't take it at all, but then on the days when he takes it, maybe he takes 2 tablets 3 times a day. So as we start reducing that fentanyl patch, it's important that we're stabilizing that oxycodone dose so that they don't have high days when they're taking a lot more oxycodone. That will help a more smooth process, and also, again, reduces that risk for overdose through that reduced tolerance that patients experience as they taper. So on the screen, you can see examples of how this taper might look. And so again, reducing the size of those fentanyl patches every month while you're stabilizing and holding that immediate release dose. And then finishing the patch, and then tapering off the oxycodone after that point. Even patients that maybe aren't on an immediate release oral product with those fentanyl patches might need a little bit of that at the end. As we think about a morphine equivalent dose to a fentanyl patch, the smallest strength are those 12 mic patches. And so that's equivalent to nearly 30 milligrams of morphine. And stopping that without continuing to reduce gradually can be difficult for patients. And so they might experience more withdrawal symptoms. So adding in a lower dose, short-acting immediate release product may be very helpful for them in that tapering process. Thank you again for listening to me today. I appreciate it. If you have any questions, contact me at cunningham.julie2, that's the number 2, at mayo.edu. I'm happy to follow up with any questions that you have, and appreciate your time in listening to this presentation today.